I'm Kristen Maitland. I'm an associate professor in the Biomedical Engineering Department at Texas A&M University. I develop optical technologies for detecting early stage cancer. We focus on the oral cavity, and there are a number of optical techniques that are currently used clinically to help dentists and clinicians detect the most severe case of disease in the oral cavity. Current standard of care is that a dentist or an oral surgeon will visually look at the oral cavity, and then they will also palpate or feel for any abnormalities in the mouth. Then they choose an area that they think is maybe precancerous or cancerous, and then they'll take a biopsy and they'll look at it on a microscope. The challenge in doing this biopsy is that many areas within the mouth in these conditions look to be abnormal, but it's very difficult to differentiate between a pre-malignant or a malignant site and a benign lesion. They tend to look very similar. Another challenge is that many of these conditions have these lesions all over the oral cavity, so it's a large area to look for something that's small and abnormal. There are some clinical technologies that are currently used, and they look at autofluorescence in the mouth to try to differentiate those, the pre-malignant site from a benign site. The challenge with these current technologies is that they also pick up inflammation, and it's difficult to differentiate inflammation from which can be benign and pre-malignancy. And so what we are hoping is that our contribution to these technologies would be more specific and be able to differentiate the pre-malignant from the benign lesions, which is a very challenging problem. Fluorescence lifetime is looking at the time that it takes for the fluorophore signal to decay. And we are taking the fluorescence lifetime of each pixel within an image. And we're using both the fluorescence intensity in different spectral channels and the lifetime within those spectral channels, so different wavelengths, to look at different chromophores within the tissue. The three main chromophores that we're looking at are NADH, FAD, and collagen, and these are in the epithelium and in the underlying stroma, and these are different biochemicals that change in either their concentration or their expression or their structural properties that then change the optical signature that we collect from outside the tissue. And so with fluorescence lifetime imaging, we're looking on a macroscopic scale to look over an area of lesions that might have multiple lesions and looking for this biochemical signal from the lesions that give us a high-risk area. After imaging with fluorescence lifetime on the macroscopic scale, we then go in with high resolution with reflectance confocal microscopy. The purpose of the reflectance confocal microscopy is that we're getting information about the subcellular structure. So we're really looking at nuclei, and these nuclei are features that the pathologists are looking at to identify pre-malignancy or malignancy in tissue. And typically, as tissue becomes pre-malignant or malignant, the nuclei become larger and they become more crowded and they become more disorganized. And so we're really looking at, on a microscopic scale, the nuclear structure within the epithelium. What we're hoping is that the fluorescence lifetime imaging will be a very sensitive technique that can find changes in tissue, and then with the reflectance confocal microscopy we can have a more specific diagnostic where we're really identifying whether the tissue is pre-malignant or malignant. So the tool that we're developing, we're hoping that it will help a dentist or a clinician or an oral surgeon to identify the most severe site within the oral cavity so that they can biopsy the correct site that would give the most accurate diagnosis that might represent the worst case within the oral cavity. It could also be used for guiding treatment. So as a tumor is resected, they could look at margins or look in other areas of the mouth. It could also be used for chemotherapy treatment and monitor over time without taking biopsies in order to determine if the treatment is having an effect. Oral cancer is a big health problem. The numbers aren't as high as breast cancer or lung cancer, but the problem with oral cancer is that if you get it, the 5-year survival rate is lower than those cancers that affect a larger population. They believe that this might be due to the proximity to the lymph nodes, so that if you get early stage disease, it might advance much quicker than some of these other cancers. And so what we're hoping is that if we shift that detection earlier, that we may be able to increase the overall 5-year survival rate by catching it at an earlier stage. So a main advantage of optical technologies in clinical care is that there's no radiation. It's a much safer procedure. It's a cheaper device than some of these very large instruments there might be one within a medical center, whereas with optical technologies you can have it in the back of the operating room, and you could have one in every operating room if you wanted to. So that it is attractive to doctors for the sensitivity and the personalized care that it provides, being able to detect changes within a patient. We've built the device, the fluorescence lifetime imaging, and the reflectance confocal microscope. We currently have it located at the Baylor College of Dentistry in Dallas, which is part of the Texas A&M Health Science Center, and we're imaging in humans, in patients with actually the dental school and with pathologists. And so we have a number of patients that come in with some benign or precancerous conditions such as leukoplakia or lichen planus. It's a very difficult population to find cancer or precancer because they have so many benign lesions, but really that's the challenge that we have to take on, is being able to differentiate or tease out these very small changes within this larger area in the mouth. So we've imaged close to 50 patients now, and we will continue to image patients and take the data, process the data, and determine how useful the technique is. It is challenging in the oral cavity because the different types of tissue, if you think of your gum or your cheek or the top of your tongue, all of those tissues are very different and they look different optically. And so having 50 patients with different sites in the mouth, there's a lot of different factors that affect our signal. So we will continue to take data and try to determine if this really is feasible.